Yeah.
Good morning.
Audible nice?
Yes, sir. Please make it full screen.
Yeah,
Yes.
I'm
Yes.
audible nice?
Yes, sir. So, good morning.
Yes.
Yes, all good, sir, all good.
Good morning, Dr. Balmukund, sir, and respected faculty and all the delegates for joining us on this Sunday morning. I request Dr. Shamina, Secretary, IAP Delhi, please say a few words.
Hello, very good morning to all, and very warm welcome on behalf of Indian Academy to all our delegates, our faculty, Dr. Balmukand,
इसमें
sir, as well as our chairperson, Dr.
इसमें
Salu, Dr.
ब्लूटूथ नहीं आ रहा
and also, our program designer and host, Dr. Maninder Dhaliwal and Dr. Veena Raghunathan. Sorry for some technical phase to delay this session. Over to Dr. Ajay.
Hello.
Yes, sir.
Request President Dr.
Just
Pankaj Garg, sir, to say a few words.
I'm putting the
Good
headphone
morning.
on so that
Yeah. Good morning, everybody. This is our last session of pediatric intensive care course. We are very thankful to Dr. Maninder and all the faculties to make it possible, and also possibly this may be the last session of 2025 for the e-master classes. We had three big master classes in this year. They started with rheumatology, then cardiology, and then intensive care. The participation has been exemplary, and all of us have learned so much into this year. So we always will be looking forward to even more master classes in the next year. We are maybe starting gastroenterology now and other topics like nutrition and other things. And request all of you to also suggest what topics best interest the delegates. Coming to today's topic,
hello.
a very important topic like hospital healthcare associated infections. Now we don't call it acquired infections because we don't know. We call it associated infections, and we have a very lexi of speakers on this. Dr. Bal Mukund, and is being moderated by Dr. Shalu Gupta and Dr. Puneet. So I will hand over to Dr. Maninder to do the formal introduction of all the speakers. And
2 minutes.
No issue, no.
Thank you, sir.
तो आपका जब complete हो जाएगा ना,
Dr. Balmunkand, can you hear me?
Yeah.
Okay.
complete हो
So
जाने तक मैं solve
your, I'll just tell you briefly, your Bluetooth is not working, so no point in putting it on. You're very audible. I can hear everybody around you. So it's okay. Let's
Achha, my
start without
Bluetooth is
the
not
Bluetooth.
working.
No. But I can hear you clearly.
So,
It is
you are
very
clearly
clear.
audible, so you
No
just
need
carry
to
on like
put
this one.
Bluetooth.
Okay.
All right.
Okay.
So
Okay.
we have a very interesting session now. So before we begin, let me introduce the moderators. We have a very senior faculty with us, senior mentor from DMC Ludhiana, Dr. Puneet ma'am. She is a mentor of mentors. She has actually made a lot of students, and we are all followers of Puneet ma'am. And we know it's not easy to manage hospital-acquired infection. So we definitely require her inputs whenever it is required, and in the last also. And we have our close friend, Dr. Shalu Gupta, Director Professor at LHMC Kalavati Hospital. Welcome, Dr. Shalu. He's again a DM from PGI, and he's leading the India's largest children's hospital. So it's great to have such experts with us to moderate such an important session. And the speaker is none other than our infectious disease specialist, again a DM from PGI Chandigarh, Dr. Bal Mukund, a very close friend. And it's a pleasure to have you here. He's also leading the pediatrics and PICU at INS Ashwini. It's a naval ship hospital, and it's a proud pleasure and honor to have Dr. Bal Mukund with us. Over to Dr. Bal Mukund to please carry on with the session.
Yeah. So to start with, disclaimer, hospital acquired, purposely I have put this name just to make it aware that we should not call it hospital acquired infection. It not only has bad connotation because the common people think that we have given the infection, and that's why the name has been many years back changed by CDC to hospital associated infection. So when Dr. Maninder gave me this topic, I asked him how to go about this, what all he wants me to cover, because it's to cover same in 45 minutes to 1 hour. It's not easy, but I'll start with cases, and just through cases we'll try to learn which we see in day to day. These are actual cases either I have seen or Some people have discussed from the AIMS Bhubaneswar or some other medical colleges, the faculties. AIMS Madurai, one case is there, one case is from PGI Chandigarh is there. So there are 7, 8 cases. We'll just go through all cases and we'll try to learn and we'll try to solve all the dogmas related to there. So this is 5-year-old male child, fever of 3 days, dysuria, lower abdominal pain, no renal angle tenderness. So there is no problem. There is no doubt about the diagnosis that most probably we are dealing with UTI. And child is symptomatic, fever, and the bedside leukocyte strays and nitrite was positive. Urine culture showed E. coli. Now, see this culture report. Which antibiotic and why? So we commonly call it ESBL. What is ESBL? You can see in this culture sensitivity report, it is resistant to ceftriaxone. You can see where is ceftriaxone. It is resistant to ceftriaxone. So that's why. So learning objective, we'll learn about what is ESBL, what is the definition and importance, what are carbapeneminases, that 5 great carbapeneminases that all intensivists and pediatricians should know. How to choose antibiotic in different GNB ESBL. There is a lot of confusion. There is a lot of misconception about how to choose these antibiotic, and we cannot ape the West because the MBLs, that beta-betolactamase, is produced by different GNB in West is different from us, which I'll show you with the examples and data, latest data till 2025 also, how it's different and why there we cannot ape the data of IDSA or any of those research recommended antibiotic. We'll learn case scenario of enteric fever and few other fungal infection, how to manage crab infection because we see a lot of Acinetobacter in our setting, how to manage Stenotrophomonas, XDR and MDR Pseudomonas. We'll read that MDR and no more it's called XDR, it is called now DTR Pseudomonas and DTR plus Pseudomonas. And what are those definitions? I'll just cover those and how to choose antibiotic. A special scenario in staph sepsis, there are few terminology that I want to clarify. VAP, CLABSI, COTI, we'll learn from what is CDC recent recommendation in Jan 2025, and I'll just briefly 1 or 2 slides I deal with the basics of fungal diagnosis and emergence of resistance to antifungal. So in the last week master class, all of us, we have learned this BMQ, that is susceptible clinical breakpoint divided by MIC. So what we know that what is basically susceptible breakpoint, which is given by the basically CLSI or UCAS, they publish these guidelines. And MIC is the lowest concentration of antibiotic, which is prevents the growth. All of us, we know this, I don't want to stress. So why it's important to know BMQ, that higher is the BMQ and and you are getting lowest concentration of antibiotic, which is in the laboratory setting lowest. So higher BMQ will generally indicate that you will be higher success rate clinically. And this has been proven in the Merino trial and meropenem based trial, that even if they are sensitive from, see earlier the cutoff of meropenem was 16, and the this famous trial saw that as the concentration was higher from 2 to 4 to 8 to 16, the mortality kept on increasing. So it's not just sensitivity, even these BMQ level actually affect the mortality. So if you see the MIC break point, why I want to sensitize pediatrician, that the break point of antibiotic is different for different organisms, and it keeps on changing every year. So CLSI and UCAST comes every year with the new breakpoint. It is freely available data that which every microbiologist has. So they give, like for Enterobacteriaceae, if you see the latest breakpoint for it, it is susceptible for meropenem is less than 1. And for resistant, it's more than 4. Just in 2021, it used to be 16. So just in 2 years, these MIC breakpoints actually change it. And this is also based on dependent dosing regime. Like this breakpoint is only when we give 8-hourly regime with infusion of 1 hour. However, we know that because meropenem has prolonged, time-dependent killing, we give a longer infusion, especially in ICU patients. So this MIC breakpoint and what we follow is slightly different. So these differences, we should be aware of this. And these are the latest 2025 breakpoint cutoffs for all the infection. You can see this is a whole lot of list, and I'm not going to deal so this, but this is freely available in public domain. But however, the pediatrician should be aware that it's only not MIC breakpoint or clinical breakpoint which is important. It is also important that we see patient as a whole. So whether it's a severe life-threatening infection, whether patient has some concomitant organ insufficiency, renal insufficiency, or elderly patient, or if there is a obesity because volume of distribution will be high. So drugs like TG cycling will fail miserably in obese patient. Where there is a patient has some infections and particular site like meningitis, endocarditis, whether these particular antibiotic has good concentration in the lung, like TG cycling, the concentration in the lung is very pure, so it's a very poor choice of antibiotic when you are dealing with the lung. Piperacillin, we all are aware that piperacillin we have been oftenly using, but you will be surprised that the piperacillin failure in necrotizing pneumonia and empyema, it fails badly. So for these infection we should never use. Similarly, it also depends upon their risk of toxicity which particular patient may be having, like renal toxic. We know all these antibiotics, aminoglycoside, vancomycin, colistin, these are highly renotoxic. So it depends upon the antibiotic choice, depends upon all these. And vancomycin, MIC creep, I'll just go through all these later. This is second case. 5-year-old child returned from Bangladesh 2 weeks back after meeting relative. Fever 10 days, mild pallor, hepatosplenomegaly, on symptomatic treatment on OPD basis. He was toxic looking, 4 hours at admission, developed compensated shock, was given fluid boluses, he was on AP.2, he was mildly delirious. So it's not a brainer that it's a most likely tropical fever, enteric fever. It's TLC, DLC. You can see he had mild thrombocytopenia. Malaria was negative, dengue was negative. So how do we choose antibiotic in this case? So typically, enteric fever we choose. On OPD basis, we choose cefixime or azithro. However, once this child is admitted due to shock, we generally give subtraction, but the history is very typical. This patient came from Bangladesh. Now, both are eastern and western neighbor. Both Bangladesh and Pakistan are notorious for drug resistance entry. And that's why when we are dealing with such patients, we should be aware about these history, which will change our antibiotic choice. And in this patient, steroid was started because of shock. And we know that any patient of enteric fever who has CNS manifestation or has developed shock will require high dose dexamethasone, that is 1 mg per kg for 48 hours, and it is known to decrease the mortality. So what I want to see, Maninder specifically told me to cover this enteric fever, don't use Vidal. Vidal is a useless test. We have seen so many cases of Vidal positivity with 320 titers and turned out to be dengue, turned out to be malaria, and we just treated those infections. So Vidal is absolute now. Have modern culture methods, Bactec method are very good, and they give excellent culture century provided you collect it with the adequate sample and during good time. So adequate blood sample is very important because this is an intracellular organism, and if you don't take adequate blood sample, you will not get culture positive. So modern culture methods are very good, and they are good sensitivity, and bone marrow culture, though we don't do often, has very high sensitivity even with 5 days of antibiotic. So if we see the MTR enteric fever, by definition, they should be resistant to chloramphenicol, ampicillin, and cotrimoxazole. Fortunately, most of these antibiotics are not used, and MDR is almost more than 95% enteric fever in India presently. XDR, by definition, additionally should be resistant to ceftriaxone, ciprofloxacin. XDR enteric fever in India, fortunately in pediatrics specifically, are extremely rare. The only places where it has been found is I said neighboring state than Bangladesh and Pakistan. So when people travel from these two states, they transfer these XDR, enteric fever, salmonella to us, and then we get outbreaks in surrounding these states. And these are basically chromosome and plasmid mediated. MDR in Asia, especially in our country and Indian subcontinent, are basically H58 strains, and these are having these genes: cat A1 gene, BLA-TEM gene, DFR A7, SUL1 and SUL2. So these are all genes which are responsible for this MDR and XDR strain. As I said, that XDR strains, which are fortunately rare in Indian, still rare in Indian subcontinent. However, if you have population in these two surrounding states, that is Punjab, Haryana, and West Bengal, you have to think of XDR. However, for these, fortunately, XDR are universally sensitive to carbapenem. So carbapenem is drug of choice for XDR strain. So in pediatrics, I have specifically the famous CMC Vellore has done this study, and they found that all strains of enteric fever in India are ceftriaxone sensitive. In pediatrics, I am a specialty. However, in adult, XDR is quite common. Even there are outbreaks even in South India of XDR salmonella. So chromosomal mutations are also known, like QRDR, which cause GAIR-A and PAR-C. So these are all chromosomal integrated resistant cassette which cause this XDR in enteric fever. This is third case. This is in RPICU, 13 years old, SC1A mutation. This is basically one of the sodium channelopathy. He was on 5 multiple anticonvulsant, fever of 2 days. He had refractory status. The problem with this C2 sodium channelopathy is that many of these anticonvulsant cannot be used, and if you use them, actually they increase the seizure, like phenobarbital, thiopentone, and even general anesthesia you cannot use, like sevoflurane. All these cannot be used, so all these requires a special care. So this we went up till Midas 18 mics. However, he had hypotension, he required inotrope, and then he had, after 12 days, he has worsening ventilatory parameter, increase in FIO requirement. He had fresh pitch, fresh patch and copious secretion. So he had VAP. There is no doubt about it. Despite our best of effort, he was not on antibiotic. We had to start antibiotic. He developed the BAL fluid. We did bronchoalveolar lavage, and it was Acinetobacter and Klebsiella positive. Now, how do we choose this antibiotic? I'll just share in following slide. These are the X-rays. I'm just skipping because I've already, there was paucity of time. So for documentation of VAP, ventilator associated pneumonia, what should be there? So there should be clinical finding, radiological finding, and ventilatory, change in ventilatory parameter. That is when you get increase in FIO requirement by at least, by definition, CTC definition is 30%, or increase in pressure requirement. So there has to be clinical deterioration on ventilation. Then only we should suspect that. And this is how he developed both the infection. So if we see the adult, definition of VAP, this is how we start with ventilator-associated condition. Then there is a clinical parameter which defines the infection-related ventilator-associated complication. And then on the basis of culture, if there is a positive culture or if there is a sputum more than 25 nitrophil, we call it possible pneumonia. And if there is a quantitative culture, that means like on the aspirate more than 10 to the power 5, or on the culture more than 10 to the 5, or we are doing brushing and more than 10 to the power 3 CFU, we call it basically, all these are, we call it probable pneumonia. So all these are basically surveillance definition. For clinical definition of VAP, there has to be both clinical worsening, plus there has to be radiological worsening, plus there has to be any of those, any of these positive culture or any of these aspirate should be positive to call it VAP. So when not to consider VAP, so if the patient has developed deterioration, any of these clinical or radiological deterioration within 48 hours or so, time cutoff is very sacrosanct. It has to be more than 48 hours to call it VAP. If there has been just plain fever, however, there is no clinical or radiological deterioration or change in mechanical ventilation requirement, we cannot call it VAP. Only fever, we cannot call it VAP. Think of other infection, healthcare associated infection like COTI, CLABSI. Don't label everything to the VAP only, because VAP is one of the commonest. However, CLABSI, COTI are also common in clinical scenario. Just ET aspirate showing PCR positive or culture. However, there is no change in ventilator pathological worsening in last 48 hours. We cannot call it VAP, because we know that within 12 to 24 hours, all ET get colonized. Antibiotic, see report, see your HICC data of last year, have latest scientific knowledge of your area, because I said we cannot ape the data of the Western. We'll see subsequently in subsequent slide, and then choose the antibiotic. Don't send ETTP, ET tube tip culture. It is colonized with biofilm. It will give you erroneous. It may not connect with your actual organism of VAP. And most in Indian setting, as per latest data of 2024-25, these are three common organisms of VAP, that is CRAB, that is Acinetobacter, Klebsiella resistant Acinetobacter baumannii complex, Klebsiella, and Pseudomonas. So IDSA says in 2024, this first document came in 2023, and subsequently they revised in July 24. So ideally, all of these ESBL organisms have CTX-M15 gene, TEM and SHV beta lactamase. Since this we cannot do routinely in lab, what they say that any gram-negative organism, if they are resistant to ceftriaxone, that is, when the MIC is more than 2, we should use as proxy for ESBL definition. That means in your antibiogram, if you are seeing ceftriaxone resistant to GNB organisms like Klebsiella, E. coli, or your Pseudomonas and or Proteus, and if you see ceftriaxone MIC is more than 2, it should be called ESBL. It is, however, it's an indirect marker, because we cannot do measure these enzymes like CTXM, M15 or TEM or SHV beta lactamase, and this is a surrogate marker. So whenever you see gram-negative organism and you see ceftriaxone MIC is more than 2, assume it as a ESBL. This is exact definition of ESBL. Now, once we see this ESBL, you should know that most of the healthcare associated infection, both in adult and pediatrics, are ESBL organisms when it is healthcare associated. In community acquired infection of GNB, if they are isolated GNB, it is at least 3 to 4 times more common than the pediatric. So we are very fortunate that ESBL as a community acquired infection in pediatric population is still almost 4 times lesser than the adult population. So pediatric. So all these ESBL infection, if they are carbapenem sensitive, carbapenem is drug of choice, provided you are dealing with a sick child. If you are not, like you are dealing with, say, cystitis in an adolescent, then it's different. However, in a small child, all these, even a pyelonephritis or any BSI, carbapenem should be the first choice. Now, it may happen that 60 to 70% of these patients are also, these antibiogram also will show resistant to carbapenem. In critically ill sick child, when many of these patients are hypoalbuminemic, avoid ertapenem. So many of these antibiograms will show ertapenem. I'll show why ertapenem sensitivity. It is important to see ertapenem sensitivity, because meropenem and imipenem are typical carbapenem that we commonly use. However, you should know that beyond these ESBL organisms also can have carbapenem resistance due to non-carbapenemase causes. That means they are not secreting carbapenemases. However, there may be AMP-C enzyme, or they may be efflux pump, or they may have change in inner or outer cellular membrane, and they can also develop carbapenem resistance. So for using this ertapenem, I'll show you what is the connotation, clinical connotation in one of the case and slide, that why it's important to know even ertapenem. So ertapenem we don't use in critically sick child because the hypoalbuminemia in these patients will displace ertapenem. Ertapenem is predominantly protein bound. There will free fraction increase, it cause increased clearance, and there will be failure and more mortality in critically sick child. We use a lot of piperacillin. I see a lot of pediatrician and intensivists use they use piperacillin. So if you see the latest data of piperacillin, most of the IDSA recommendation and European actually piperacillin and tazobactam, they recommend this should not be used for any infection outside the urinary tract. And there are reasons to it why they are saying that it should not be used. First, you should understand that piperacillin tazobactam has to be given 6 to 8 hourly. All of us are giving 6 to 8 hourly. If you see T half of piperacillin and tazobactam, piperacillin T half is 1 hour, tazobactam is around 1.8 to 2 hours. So there is a tazobactam component which is there in the blood. However, piperacillin is not there, so tazobactam cannot work. So you have piperacillin in the body, you have tazobactam in the body, but piperacillin is not there. So it is actually, this choice is a poor choice for especially ESBL outside the urinary tract. For a urinary tract, it is an excellent choice. However, outside, there is also some effect called inoculum effect. I don't know whether people have heard about this inoculum effect. I have a separate slide for this effect. This effect is when the bacterial concentration, like in a necrotizing pneumonia or empyema, increases. Because of inoculum effect, the MIC keeps on increasing the organism in the same colony, in the same locus. And that is the reason that there will be failure of piperacillin tazobactam. And the ratio of piperacillin tazobactam is 1:8. So this ratio also, the lower dose of tazobactam is known to cause failure. So there are reasons that piperacillin tazobactam is no more recommended outside the urinary tract. And there's especially patients where there is a high, bacteria burden like infective endocarditis, necrotizing pneumonia, empyema. This piperacillin tazobactam should not be used. There is just like we have heard the bell-shaped curve, the moment we cross the bell, when the bacterial load is high, the efficacy keeps on going down of piperacillin. And it is especially well known with the cefepime and piperacillin tazobactam. However, it is also known with the other antibiotic, including carbapenem, especially imipenem. It is well documented in Pseudomonas HAP, where there is a high burden, high inoculum versus if there is a UTI. So if you have failure of these antibiotics, when there is a high burden of bacteria, especially in these conditions, you might have to change, the antibiotic. So I was quoting this. You can see the second para, piperacillin tazobactam, the half-life, 1 hour versus 1.5 hours. So the problem with this infusion is that when your tazobactam is there in the body, piperacillin, the main antibiotics, is not there in body. And that is why one of the reasons that IDC recommend that piperacillin tazobactam outside the urinary tract should be avoided. This is 4th case, 6 weeks old baby, NICU graduate, born at 35 weeks, 1.89 kg, had LONS with meningitis, was treated with meropenem 14 days, culture negative, PCR was also negative. He was discharged at 31 days. He came back after 2 weeks with poor feeding, lethargy, and you can see this. He had with seizures. The neuroimaging showed 2 big, large abscesses. And what they isolated, neurosurgical intervention was short. They did drainage. And what they found that Citrobacter fundi, it was sensitive to ceftriaxone. And baby was started on ceftriaxone. Sorry, it is not cefotaxime. It was ceftriaxone and Amica. Amica, I think neonatology people are still giving a lot of Amica. Amica has a poor CNS penetration beyond the neonatal period. We don't use, but they are fond of. However, the baby deteriorated despite antibiotic, and he died after 5 days of admission. So it's despite sensitivity, why he died. So you should know that there is something called AMP-C enzyme. Now, AMP-C is basically, it causes cell wall cycling in the gram-negative infection. AMP-C is a typical organisms which these three organisms are notorious to produce. That is Enterobacter cloaca complex, Klebsiella aeruginosa, and Citrobacter fundii. If you have these three organisms in the culture, even if it is showing the ceftriaxone sensitivity, you should never use ceftriaxone, because it is well known that even if you use 1 or 2 doses of ceftriaxone, they develop MC enzyme, because MC enzyme is an inducer enzyme. The moment you give 1 or 2 doses of ceftriaxone, the MC enzyme get activated and they develop resistance to it. With even 1 or 2 doses. These are plasmid-based enzyme, and they become resistant, and your patient will deteriorate despite showing. So they are found in the basal level, and they are involved in the cell wall cycling. It hydrolyzes many beta-lactamases, and so there are 3 mechanisms to this MC enzyme. One of them is MC enzyme production, and they are known to be resistant with ceftriaxone, cefotaxime, ceftazidime, azithromycin, piperacillin, tazobactam, and imipenem. That means if you see these 3 organisms which I showed, Enterobacter cloaca complex, Klebsiella, and Citrobacter fundii, because these are notorious to cause neonatal cerebral abscess. If you see, Nelson, the commonest organism for neonatal cerebral abscess is Citrobacter and Enterobacter cloaca complex. You should avoid all these antibiotics, even if they show sensitivity, because they will induce MC enzyme and all your antibiotic will be ineffective. What is effective in these organisms is they are generally meropenem and cefepime are recommended antibiotic for these MC enzymes. So one of the common queries are carbapenems. Once you see that your GNP is resistant to, say, ceftriaxone, the next step is to see whether they are sensitive to meropenem or imipenem or not. Now, 90% of GNP will be, or ESBL, extended ESBL, in present surrounding in the adult, and 70% of our in PICU will be resistant to carbapenem, all these ESBL. So when we are talking of carbapenems, there are 5 major carbapenems that clinician should be aware, which is actually classified according to Amber's classification, which is class A, B, and D. The most important that we need to be aware is class B, which is NDM. Now, NDM is notorious because percentage of NDM in last 4 to 5 years has increased in crab, has increased in pseudomonas, which was less than 5 to 10%. Now they are secreted in 50 to 60% of crab. So 5 great carbapenems that we should be aware is NDM, VIM, IMP, OXA48, and KPC. Fortunately, KPC, which is basically class A as per Amber's classification, as rare in India. Most common are NDM, WIMP, IMP, and OXA48. Out of this, NDM is most notorious, and we'll see how it is notorious because it lives with very few choices of antibiotic to us. And you will be surprised, there is a regional variation in NDM. That means if you see the Western India, the percentage of NDM in, say, Rajasthan or surrounding Gujarat is much more than the eastern part. Similarly, in southern part, this is a famous study which published into ICMR, sponsored study in Pseudomonas. And what they saw that there is a lot of regional variation from 5 to 40%. So imagine one choice of antibiotic in one region may not be helpful in another region, because if, as per IDSA or any microbiologist or a UCAS guideline, whenever we are having empirical choice of antibiotic, ideally it should cover 90% of your bacteria in critically ill sick child. So imagine same NDM, which is less than 5% resistant in one region. In Western India, it is 40% are NDM positive. Like in, say, PGI Chandigarh, they found 23% resistant. However, in CMC Vellore, they found only 9.5%. So here, probably, if we see North India, NDM cover of Pseudomonas was mandatory even in 2018 and 19. However, in South India, it was not so common. So there is a lot of regional variation. Why we need to know? Because we know that every hour in delay, this in 2006 famous article is still quoted everywhere. Each hour delay in antibiotic increased mortality by 7.6%. To remember, 8%, approximately 8%. And that's why choosing antibiotic appropriately in ESBL, which secretes carbamazepine, are very important. And I'll just go through cases how we choose antibiotic depending upon these carbamazepine. So this is 2 years old, required VPSN for post-meningitic hydrocephalus CSF is normal, however, developed fever on D2, post-op, irritable, not tolerating food, put on MEN, Procalis, 98. So there is no doubt that he has some infection. Blood culture report showed this. So will ceftazidime avibactam will work on this? So now if you see the organism is Klebsiella pneumoniae. Now Klebsiella pneumoniae, which is ESBL, and you can see it is ESBL because it is ceftriaxone resistant. One more thing I want to stress, in ESBL infection, if you see ceftriaxone resistance or cefotaxime resistance or ceftazidime, even one of these three antibiotics, one resistant, you cannot use another two antibiotics. That means if an organism is showing, say, ceftriaxone resistant, but sensitive to ceftazidime, you cannot use ceftazidime. All these have a common mechanism, and the study has found that if you use in ESBL, even one antibiotic is showing resistance, another antibiotic, the mortality is more. So in a sick child, if you have any of these ceftriaxone, cefotaxime, ceftazidime resistant, please avoid using in any of these antibiotics and go to carbapenem in a sick child. So this organism, Klebsiella pneumoniae, you can see is ceftazidime avibactam is resistant. So can we use ceftazidime avibactam? So answer lies is that ideally we should do carba expert. Expert carba cost is around, has come down drastically. It was initially to start with was 15 to 16,000. I has now come to 6,000. What it does is basically it gives the result within 2 hours, and it is basically PCR based test. It detects the color change to carbon producing Enterobacteriaceae and Pseudomonas. However, it requires culture positivity. That means you have sent a bacterial culture, it is showing flagging some positivity. You do some, you take a sample from there, do that PCR carba expert, and it will give you a report like this. So it covers 5 major carbon, that is IMP, WIMP, NTM, KPC, and OXA48. And depending upon the positivity, we choose the antibiotic. Now, this Klebsiella pneumonia was OXA48. So till 2020 to 21, in India, the carbapenem, that is carbapenem resistant Klebsiella, the 30% were NDM positive, 30% were OXA48, and around 35 to 40% were both secretor of OXA48 and NDM. If you see the Western data, USA and European data, they don't see NDM so frequently. What they show is KPC producing. In India, we don't see KPC producing. KPC is less than 2% in India. So in India, that also in few reasons. So we in India, Klebsiella are not KPC producing. They are predominantly NDM and OXA48 producing. So our choice of antibiotic should cover NDM mandatorily when you are dealing with the Klebsiella. If you have like this OXA, it's only OXA48. So ceftazidime avibactam will be sufficient in this patient if it's not NDM. However, if had this same organism had been NDM positive, you have to add azithromycin, ceftazidime avibactam, and azithromycin, because azithromycin is the only antibiotic which will, in periplasmic space will disable the NDM, and it will be effective in such patient. Next case, 60-year-old girl admitted with 60% flame girl. These are actual cases. He was managed for 36 hours. She was lethargic, hypotensive shock with oliguria, severe metabolic and lactic acidosis. She required fluid bolus. She was on NORAD infusion. She was intubated on RRT, was commenced. She was started outside initially, meropenem, polymyxin B, teicoplanin, mycophenolate. So don't ask the choice of antibiotic. This is how she came from the outside civil hospital. blood culture in GNB within 8 hours. Now, what kind of test actually we can do in such scenario? This is a very sick patient with 60% burn, septic shock, on inotrope. So this is the new investigation which has been available in many of these actually new labs. This is called BCID panel, that is Biofire Culture Identification Panel, and it is a multiplex ACR based channel which detects 33 organisms and 10 resistance genes. It doesn't give antibiotic sensitivity report, but because of these resistance gene, you can hone down to antibiotic and they help you. And turnaround time is just 2 hours. So how beautiful! There is no need for culture better, like we saw in the Carba Expert, which will require culture positivity, and from there you can take. This doesn't require color, and it has excellent sensitivity and specificity. There are multiple European study that it has sensitivity of 98 to 95 and a specificity of 95%, quite high. So in sick patient, this is one of the excellent investigation, and most of the labs are having. And how do we get this? This is the typical report of Biofire. This is from our hospital. You can see it will show you CT exam, cholesterol resistant. Same carbapenem resistant. It is showing Klebsiella positivity. And see, this organism, unlike the previous Klebsiella, is both OXA48 and NDM resistant. Since it's NDM resistance, here it is mandatory to act Septaginium avivectum on top of that azithromycin to disable in periplasmic space of this Klebsiella. So that's how it is helpful. It's a small investigation, and you can save not only the patient a lot of life. So there's a conventional method that we have been using. There is another method which is now available in many of these advanced labs. Hinduja, it is available in Mumbai, and many other labs is multi-top DF. The turnaround time of multi-DF is just 30 minutes to 1 hour. What is it? It is a matrix-assisted laser reabsorption ionization based on mass spectrometry. What it does is that it is based on the mass to charge ratio, and it detects the ionic particle depending upon the movement, and it will cause rapid detection. All the fluid and fluid secretion can be used. However, and it's also help in serotype diagnosis. Multi-top is available nowadays, many of the good labs. However, it is a costly investigation, cost around 15,000 and so. However, it does not give susceptibility and microbiome detection. So many of these labs are doing multi-top. If your lab is there, I think few INI also has now multi-top. So Klebsiella pneumoniae, if you see the 2021 data published by CMC, the 20 to 30% were NDM isolated, 35 to 45 were both NDM and OXA 1 and 48 producing, and 30 were. However, the recent evidence 2024 CMC Velour data shows that recently 80% of now Klebsiella pneumoniae are NDM secreting, either NDM with the OXA 181 or 232 or with the OXA 48. So these pattern has been over just 3 to 4 years. That's why it's important to remain updated about these ESVL infection, because the choice of antibiotic is changing. So if initially was only OXA 48, now since because NDMs are more than 80%, it is important to add azithromycin, because azithromycin neutralizes NDM. Now, if we see the E. coli, 90% of CRE E. coli in India are NDM producing, and there is something called PV3 insert, then penicillin binding protein 3 insert in the cell membrane of E. coli, which happens due to Vyric mutation. This is present in almost 90 to 100% of E. coli in India. This is typical in India. However, in Western country, this PV3 insert is only in 20%. So in Western country, if you just cover NDM predominantly in E. coli, it will work. That means Septaginium avivectum azithromycin will work excellently in E. coli. However, in India, if you use same regime that is only NDM cover, it will not work, and you will have mortality. I remember Shah sir was, called me about one ALL patient who died of E. coli sepsis within 6 hours while febrile neutropenia, because was covered only with the NDM. Because you have to cover, because our patient of E. coli, when they are carbapenem resistant, most of them, that means more than 90%, have this PV3 insert due to virus mutation, and they will not be covered only pure V. So here we need to add colistin based or polymyxin B based regime to have optimum outcome. In our setting, Pseudomonas like 80% are MBL producer, and a main MDL producer in India in 80% of Pseudomonas are again NDM. Same, and if you see the Western data are non-MBL producer, only 5% are MBL producer. MBL is meto beta lactamases, which are predominantly NDM and WIM in Pseudomonas. So in Western country, if you see Pseudomonas, MDR and XDR, they are non-MBL producer. That means they are not secreting NDM. They have not more than 5%. In our country, it is almost 2/3 of Pseudomonas that will be MBL producer. And that's why the antibiotic regime of our Pseudomonas and their Pseudomonas has to be different. Similarly, if you see the R's data, 70% of Acinetobacter are carbapenem producer, and 30% are again MLB producer. So this is courtesy Professor Balaji, very famous microbiologist of international repute. This data is taken from Sir's class, and what he showed that 80% in their in CMC Vellore study, he found that 90% of CRE are NDM producing with 4 amino insert when they are carbapenem resistant. Klebsiella, 80% are NDM and OXA producing. Pseudomonas, again 80% are MBL producer. So it was data 2 years back was 60%, now 80% are MBL producer. And that's why our Pseudomonas, if you cover with Western choice of antibiotic, our patient will die. And Acinetobacter, again, 30%, 70% are carbapenem and 30% are MBL. So we heard about this NDM. What is New Delhi meta-lactamase? There are 60 enzymes, basically. There are 60 types of it. And most important is NDM1, because it significantly alters, it hydrolyzes all antibiotic except azithromycin in periplasmic space. And that's why azithromycin is a mandatory component when you are suspecting NDM, either confirm or suspecting NDM. So what are the recommended antibiotic when you have a ESBL organism which are NDM producing or likely to be NDM producing, which I showed the data that most of our organisms are now. So we doesn't have much of choice. We have either ceftazidime-avibactam with azithromycin or the cefiderocol antibiotic. Now, cefiderocol only one company makes in India. The cost is too high, just for 40,000 each vial. So, but the ceftazidime-avibactam azithromycin is cheaper. That is a better antibiotic. Why we add ceftazidime-avibactam to azithromycin? If we want to cover, we know that azithromycin is effective against NDM. Then why do we add ceftazidime-avibactam? The answer is that many of these organisms also had concomitant other, hydrolyzase like MC, KPC, OXA48, and that is the reason that we always add an NDM producing ceftazidime-avibactam with azithromycin to have an optimum effect. Now, this is one recent study in 2021. There are only 2 places where we use despite carbapenem resistant carbapenem. That means your antibiogram like GNB is showing carbapenem resistant, but despite that we add carbapenem. One place is when you have E. coli, which is resistant to carbapenem, and because of PV3 insert in these organisms, they become insensitive. In fact, the mortality will be more even if you use colistin. So what this study found that when you use with the aminoglycoside carbapenem, despite in antibiogram showing carbapenem resistance, it has actually synergistic effect. And over the years, what they found that last 2 to 3 years, this actually brings down the MIC level. And they found that the when this E. coli are secretor of NDM1 and NDM5, actually it is helpful because of this synergistic effect. So this is one place where even if your antibiogram is showing carbapenem resistance, that is imipenem, meropenem resistance, you can use this antibiotic along with aminoglycoside to have optimum effect. However, you should be aware that aminoglycoside are not a good choice of antibiotic in BSI because the mortality is more. Aminoglycosides are good for urinary tract infection and pyelonephritis, not a very good antibiotic. Isolated aminoglycoside for BSI and any of the ICU infection. However, with the meropenem in resistant E. coli, it is an excellent antibiotic because of synergistic effect. So next organism is carbapenem resistant Acinetobacter. All of us we see. You should be aware that Acinetobacter many times is a colonizer. It forms a thick biofilm and many times. So you should be aware that when you are sending the ETT aspirate or, not properly done bile and you are taking from the, only from the trachea, not going deep into, it may be colonizer. And so if you have a clinical deterioration along with a thick secretion or, change in ventilatory parameter, change in the FiO2 requirement, you know that most probably you are dealing with the pathogen. Now, why crab is important? Because crab produce typically oxacarbapenems. And most of these oxacarbapenems in crabs are oxa 24, 40, and 23, which are resistant to beta-lactam. They are also notorious to secrete metallo-beta-lactamases. Many of these are resistant to even sulbactam. They are inherently resistant to all aminoglycoside because of this 16S messenger methyl transferase. And they are also resistant to fluoroquinolone because of this chromosomal encoded quinolone resistance. So is one of the difficult organisms to treat. I will go. So presently, IDSC says that there is no standard of care antibiotic for crab infection. So, but we'll see the data. Now, this is the latest data from CMC. And what they found that if the carbapenem is only oxacarbapenem is, secretor, sulbactam and durolobactam is an excellent antibiotic. It is available in India. The cost of each sulbactam, durolobactam is around 4,000 rupees. There are only 2 to 3 companies who makes it sulbactam, durolobactam. They are drug of choice. Another choice is high dose sulbactam. So use, in adult, we use 9 to 12 gram, and in pediatrics, we use 300 mg per kg per dose of high sulbactam. So I'll give you how to choose these, regime in different cutoffs. If your Acinetobacter baumannii is both NDM and OXA positive, then you have very few choices. That is cefiderocol. The cost is exorbitantly high, 40,000 each vial, or cefepime zidibactam. It is available. It is not available in the market now. Next year, it will be launched. Wockhardt has researched this molecule. It is available as a compassionate use. If you contact them with your antibiotic, they do supply within 24 hours with high dose sulbactam is choice for these antibiotics. So I was saying this data only that just 5 years back, the same Acinetobacter crab was only 5 to 10% NTM positivity. In fact, in Western, it is only 5% positive. In India, the CMC Vellore, I was talking to ID department of CMC. In the May, they told me that they found that more than 50% are resistant to NDM. And when they are resistant to NDM, you have to cover NDM like cefiderocol. So when we get Acinetobacter, we have to see whether they are MBL producing or non-MBL. MBL is nothing but meta-beto-lactamases. That means either they will be producing NDM or similar enzyme. So when they are MBL producing, if it is more than 128 MIC, your sulbactam, durolobactam will not work. What will work? In them, you have to use either cefiderocol or you have to use TG cycline. So that type of choices. If non-MBL producing, which like in Western country has, if you have MIC level less than 4, you will use high dose sulbactam. If your MIC is more than 16, again your either high dose sulbactam or sulbactam durolobactam or imipenem will not work. This is another incident where in the carbapenem, that means antibiotics in antibiogram, you see resistant to imipenem and meropenem, you can still use imipenem. That is when you have crab which is non-MBL producing with MIC of 16 or less, you can add imipenem to sulbactam durolobactam, which is now drug of choice for crab infection in India in non-MBL producer. That means your NDM is negative, which will be around 50%. And if your MIC of sulbactam is 8 to 16, the drug of choice in India will be sulbactam durolobactam with imipenem. How imipenem helps in this? See, the imipenem actually has been, the exact reason is still known. What has been hypothesized is that imipenem targets the PV3 protein and it decreases the MIC level of sulbactam and it improves the outcome. And that's how it works. So there are two places where despite meropenem resistant in GNB or imipenem resistance in antibiogram, you will use imipenem. One is in E. coli along with your aminoglycoside. When there is NDM1 or and NDM5, that is, you are getting the carbapenem resistant due to NDM. And second place is when you are seeing Acinetobacter crab infection, where they are non-MBL producer and the MIC level is till 16. These are the two places where despite carbapenem resistance can be. Now, sorry. So why do we add imipenem? So I showed you that imipenem actually is, it target redundancy for enhanced killing. So actually killing enhances because of attacking of these PV3 protein. What I want to show you that you should know that the MIC testing is not best for PV based synergic activity, especially this holds true for the crab infection. That means, despite the previous slide, if you see MIC is showing 8 to 16, if you don't use PV synergy, the sulbactam durolobactam alone used will cause more mortality, because the study found that the same crab organism also have PVV3 synergy and mortality is high. And that's the reason that IDSA and many of the ID society now recommend that imipenem has to be added to sulbactam durolobactam in crab infection when MIC is still 16 in non-MBL producer. MBL is metallo beta lactamases, which are like VIM or NDM. So I was showing that NDM predominantly are in this periplasmic space of the GNB infection, this in between outer lipid bilayer, inner lipid bilayer. So if you don't cover, if the organism is NDM producer, all your antibiotic will get disabled in this periplasmic space. And azithromycin neutralizes NDM in this periplasmic space and will cause antibiotic to go inside the bacteria. Next organism is Pseudomonas. Now we know that Pseudomonas is one of the very common organism and nasty organism. So by definition, MDR Pseudomonas are generally resistant to at least one antibiotic. They are not susceptible to at least one antibiotic in at least three class of antibiotics, that is penicillin, cephalosporin, fluoroquinolone, aminoglycoside, and carbapenem. In 2018, IDSA came with a term called difficult to treat. So we are not now calling XDR Pseudomonas, we called it DTR Pseudomonas. That is difficult to treat Pseudomonas, which will be resistant to piperacillin tazobactam, ceftazidime, azithromycin, meropenem, imipenem silastine, levofloxacin, and cephalosporin. So literally they are resistant to all common antibiotics. So however, the novel antibiotics which are available in India, like ceftazidime tazobactam, is available in India, ceftazidime, they are sensitive to these antibiotics. Or imipenem silastine, rilibactam, or cefiderocol. Cefiderocol, one company still makes in India. So what are the mechanisms for MDR? So each organism for MDR or DTR, like similar to akin to DTR. Each organism has different mechanism of resistance. In Pseudomonas, there is something called PDC enzyme, that is Pseudomonas derived cephalosporinase, which is Pseudomonal AMP-C enzyme that cause actually resistance to all these. And the other mechanism are porins and efflux pump. Efflux pumps are the pump in the inner cell membrane layer, which will cause efflux of, so antibiotic going inside. However, because of efflux pump, it will be thrown out of the cell. They are also has expanded spectrum beta lactam oxa-10, and rarely they can have BIM up to 10%. So as per IDSA, when you see antibiogram of Pseudomonas, if they are, say, sensitive to both piperacillin, tazobactam, ceftazidime, cefepime, azithromycin, carbapenem, you should avoid using carbapenem. IDSA says that you should use, if these are sensitive, then you should try avoid piperacillin, tazobactam, because of, I showed you the problem with BSI and pneumonia. So other antibiotic you can use is ceftazidime, cefepime, azithromycin, provided they are showing sensitivity. They are saying that carbapenem should be preserved for more infection, better infection, because the outcome has been found to be equally effective even if you avoid carbapenem. So that is the only reason they are saying that. So for crab infection, this is the latest data given by the CMC ID department, that I have already showed the definition of MDR Pseudomonas, difficult to treat Pseudomonas, which was coined in 2018. And now we have major problem. They are now called DTR plus Pseudomonas. What they do is they are producing additional meta lactamases, and which are even resistant to ceftazidime avibactam, resistant to ceftalozen tazobactam. You'll be surprised, the only antibiotic BL-BLI combination which was developed in India was ceftalozen tazobactam, and now our Pseudomonas are even resistant to this antibiotic. So DTR Pseudomonas, which were initially susceptible to ceftazidime avibactam, ceftalozen tazobactam, or aminoglycoside in combination, the new Pseudomonas, which are basically DTR positive Pseudomonas, are resistant to. So what are those antibiotics recommended for DTR plus Pseudomonas? Are cefiderocol or cefepime gedibactam. I said this will be launched. The phase 3 trial is going on. It will be launched next year, mid next year, by the OCAD and polymix based combination regime. So these are recommended regime for the DTR and DTR plus Pseudomonas. These are 3 studies for DTR. So still around 50 to 60% of our Pseudomonas are DTR Pseudomonas, and around 30 to 40% are DTR plus Pseudomonas. So for DTR Pseudomonas, both ceftalozen tazobactam and ceftazidime avibactam are generally effective. However, we have conflicting data, which is one is better. But in adult trial, have found that ceftalozen tazobactam is slightly better than the ceftazidime avibactam. Pediatric data are not there for basically choice of antibiotic for DTR Pseudomonas. So this is the IDA statement of July 2024 for DTR or DTR plus Pseudomonas. What they are recommending is ceftalozen tazobactam, ceftazidime avibactam, e-penem, cirostine, relibactam. These are all available antibiotics which are available for Pseudomonas. So next, we'll just see the definitions of BSI. I think I'll skip because all of us are aware that whenever we are defining the CLABSI or the BSI, we need to have the lines for 2 calendar days and along the symptomatology to call it CLABSI. So what is CLABSI and CRBSI? Basically, CLABSI term is used for surveillance definition, and CRBSI is the actual catheter, central catheter-related blood stream infection. So what is important for a pediatrician and intensivist is clinical diagnosis in patient care, that is CRBSI, and what is important for hospital administrative and surveillance purpose and public health tracking, comparison of one hospital to another is CLABSI, that is central line associated blood stress infection. So typically, we all know that for CRBSI, we take 2-hour differential time to positivity. That means you take two culture, one from the central line, and simultaneously you take a peripheral blood culture. And when the time to positivity, that means the blood culture initially has flagged off from the central line, and after 2 hours, the second blood culture which was taken from the peripheral line is flagging. That is called differential time to positivity. If the difference is more than 2 hours, we associate and call it central CRBSI. However, this study in 2023 found that the routine use of these DTP cutoff 2 hours has, it's quite very not very accurate, that it contains only 40% sensitivity and 74% accuracy. That means that though this cutoff has been given 2 hours, the exact scientific data why this 2 hours cutoff has been given is not very good. That means you may have CRBSI even with 1 hour or 3 hours positivity, and still it may be CRBSI. So though IDSA is saying this cutoff, but their evidence is also poor for this differential time to positivity of 2 hours. Meaning thereby, even if you get after 2 hours, or after say less than 2 hours, and if your clinical symptomatology matches with CRBSI and you don't have any other infection to associate in this healthcare associated infection, you should label your patient for management purposes CRBSI. The next definition is COTI. COTI is when your catheter, indwelling catheter, lies in urethra for more than 2 consecutive days, and day of event is 1 day prior to that. That means 2 consecutive days it has remained, and you have infection associated with the symptomatology, with culture positivity, you will define COTI. So this is symptomatic COTI, that is any of these one symptom along with the 2 days culture positivity, and you have not more than 2 organisms, more than 10 to 5 CFU, you will COTI of any way. They have also defined the CDC less than 25 guideline has given for less than 1 year, where they have included hypothermia, apnea, bradycardia, lethargy, which is not there in more than 1 year's guideline. Also as definition of COTI, asymptomatic bacteria, there are 3 places where asymptomatic bacteria will require treatment. That is, one is in pregnancy, the another place is peri-transplant period, that is 1 month after transplantation, and when you are doing any intervention in the you are breaching the mucosal barrier, like during instrumentation, or you are doing TURP in the adult, similar to that. So any instrumental barrier you will cover even with asymptomatic. So the next is whether we should use TG cycline and eravacycline. I see a lot of intensivists actually use TG cycline and eravacycline in GNV infection and CRE infection. Actually, the data of TG cycline and eravacycline, that tetracycline derivatives are poor. They are associated with more fatally, should not be used. Why? Because the moment you give TG cycline infusion, it has a large volume of distribution. It distributes freely throughout the body, and what remains in the blood or serum concentration is very low, and it gets poorly concentrated in the urine tract. So all BSI of GNB and ESBL, you should avoid TG cycline, eravacycline, and there are enough data that basically they have associated with poor outcomes. The next infection is stenotrophomonas. Dr. Maninder especially told me to cover stenotrophomonas. This is the actual case given by the Krishna Mohan Gulla. He had a very bad patient, 4-year-old child, hospitalized since 2 months, multiple admission, ventilator dependent, on TPs, has VAP, clinical VAP, and this was the culture report he shared to me. Stenotrophomonas literally resistant to all antibiotic. How do we treat such organism? So stenotrophomonas is very typical organism. It's a gram-negative aerobic organism. However, most of the antibiotic actually which responds to which are sensitive to gram-positive are also working on. They are notorious because this secretes all beta-lactamases, including L2-serine beta-lactamase. They are inherently resistant to most of our tetracycline, aminoglycoside, most of cholesterol. So all these antibiotics will be resistant to Stenotrophomonas. So what is recommendation? If you have a sick patient, you will use two agent in Stenotrophomonas. It is very common organ Stenotrophomonas, inherently common in neonatal and infant age group. So the regime recommended are two of any antibiotic. The best regime is ceftazidime, avibactam, azithromycin combination, or two of the following, that is cefiderocol, minocycline, trimethoprim, sulfamethoxazole, or levofloxacin. Levofloxacin had a better outcome in adult study. That means why? Because levofloxacin found to be sidal for this Stenotrophomonas. Trimethoprim has been found to be a static drug. However, many of these still European don't believe in static and sidal drug, and so is the outcome, adult ICU outcome. However, for Stenotrophomonas, the outcome of trimethoprim based combination therapy is slightly poor than the levofloxacin based therapy. Minocycline presently not approved for children in less than 18 years. However, there has been off-label use. There are multiple such case reports available in the literature that minocycline people have even tried in the larger pediatric population. However, it's not FDA approved. So this is the, whatever I have given the talk, this is the basic one slide coverage of different type of antibiotic. So when you can see your organism, and if it is showing the green one, you can use comfortably. It will cover more than 90%. So your E. coli, which are normally antium oxa-48 with PV3 insert, your cefepime nacubactam, azithromycin nacubactam is still not available in cefepime gedibactam, which will be available by the next year. They are almost 100% sensitive. The other azithromycin avibactam can be used. The latest CMC data shows that around 75 to 80% will be sensitive to azithromycin avibactam of E. coli, which are antium producing annexa 48 with PV3 insert. The Klebsiella in India, we know that they are antium oxa, they are non-KPC producer. Most of these antibiotics will work quite well. Pseudomonas aeruginosa, again, they are, andium producing in India. You have to define whether it's a DTR or DTR plus Pseudomonas and choose the antibiotic as I showed in the last slide. For a crab infection, depending upon your MBL or non-MBL producer and MIC level of sulbactam, the choice of antibiotic will differ. However, the generally drug of choice are durolobactam, cerulobactam as a first drug of choice, and high dose sulbactam based regime is second alternative and second drug of choice for Acinetobacter baumannii complex. So I'll skip this slide. For MIC value, especially for crab infection, PV based synergy outcomes, actually, it is not predicted by MIC. I'll just skip this slide. This is another, very good slide. You can see that E. coli actually, the CR E. coli is one of the most fastest killer in our NICU graduates. Even if they come after 2 months, 3 months, these are one of the fastest killers. So which type of antibiotic will work? We have very few choices for this. So cefepime, if you see the normal commonly available antibiotic which is available in India presently, azithromycin avibactam is only 2/3 of them are actually effective. So what we can use is probably cefepime gedibactam when it is available by the OCART next year, or you can directly contact DRMR. They do give. We have asked for one, once, and we got through. And sulbactam, durolobactam you can use. So there are very few choices when you have these E. coli type of organism. So summary of recommendation, if you see azithromycin avibactam will work in CRE E. coli in around 2/3 of it. When cefepime gedibactam is available by the next year in 100% of the patients. So, Maninder yesterday posed the question, should we use meropenem as a continuous long infusion for 3 hours? Sadly, the data of our IDSA recommendation is not uniform. That means, though it is concentration, time-dependent killing, which we are using in critically sick 3 hours infusion, what they say, IDSA says that if you have non-carbamazepine secreting ESBL, that means in antibiotic sensitivity biogram, you are seeing the carbapenem resistance, but you are not seeing any carbapenemase enzyme in that. There are other mechanisms like MC or efflux bomb or membrane change. then prolonged infusion is recommended. That means more 3 or more hours. Now, how do we see in antibiogram? They will show resistant to meropenem, imipenem, sensitive to meropenem and imipenem, but resistant to ertapenem. When you get this combination, then they are uniformly recommending prolonged infusion. Otherwise, not recommended. However, the European guideline says that because it's a time-dependent killing in all critically ill sick child, you should use prolonged infusion of meropenem. So IDSA and European guideline slightly varies in this. The last few slides, diagnostic evaluation, fungal infection. So if you see the commonly we use 10% K mount and 10% KOH mount. So you have, when you have broad aseptate hyphae, the diagnosis most likely will be mucormycosis. If you have a pauciseptic hyphae, this is one of the child who was referred with the cellulitis-like feature of 2 months of the face, and we could diagnose with this. There is a new, fungal infection, mycosis. It is present in immunocompetent patients, and many of these adolescents also have this infection. And just if you have pauciseptate hyphae with this, the diagnosis is almost certain. If you have oval, then it is candida, round cryptococcus, and fungal culture is also available, and we can do anti-fungal susceptibility and bacterial on that. So there are other PCR-based tests and biomarkers like cryptococcal antigen, histoplasma antigen, beta-D glucon, and galactomannan. I see a lot of pediatrician and activists using BDG. I'll cover one slide on BDG. The fungal cell also has capsular antigen, that is cryptococcal capsular polysaccharide, and cell wall antigen like one BDG, galactomannan, and mannan. Now, this is one of the study from mycology department by PGMR. What they found that the antigen persists in serum and CSF for up to 24 months, even without HIV. That means even if you treat these patients, if you keep on doing this antigen-based test, they may remain positivity. So for follow-up, you can't use, or for reinfection, you can't use these antigen-based tests. So galactomannan, I will skip this. The cutoff has been changed. So 2020 guideline has actually lowered down the cutoff of galactomannan. That is 1 for BAL and 1 for CSF, which was earlier 2. Now they have brought down. So what you should know that BAL has better sensitivity and serum has better specificity. That means if you have a plain colonization in the chest, we have published this data in 2024 Jan. One of our patients had BAL 2.6 galactomannan and turned out to be tuberculosis. What I mean thereby, if you have only BAL positivity, it is more sensitive, but it is less specific. That means that it may be colonizer. However, if you have serum also simultaneously positivity, means it has a spill from the respiratory tract to the serum. That means invasiveness likelihood is more. That means specificity is more. So if you have serum positivity, it is more specific. If you have BAL positivity, it is more sensitive. The cutoff has been changed recently. Serum is 0.5. The BAL and CSF is 1 from 2 to 1. In BDG, I am very sure that people are using a lot of BVG. It is secreted by Aspergillus, Candida, Pneumocystis. However, you should be aware that no pediatric cutoff, no guideline gives pediatric cutoff. Adolescent, we use cutoff of 80. However, you should know that many of these Candida, Parasylosis, or cruci, which is a big problem in India, Parasylosis along with the auris is a big problem in India, has low sensitivity. That means even if you have this infection, BDG may not be high. And the data are very limited. I see a lot of BMT patient people are using BDG, but you should be aware that it may be quite erroneous because our infection like parasylosis may not have adequate BDG. So present, if you see the present data, and many of these immunocompetent children also, the BDG level despite fungal infection have been found to be low. So that's why they are present all guideline and all society guideline, including European guideline for fungal infection, don't recommend BDG use in children. I have also put one slide on resistance because this is common. A lot of post-BNT patient develop fungal infection. If you see the two candida, that is Candida auris and Lusitani, these are inherently resistant to amphotericin. In India, 90 to 100% of Candida auris and Lusitani are resistant. So in them, we have to use echinocandid. You should be aware that echinocandins are not approved for use in neonate and small infant. Beyond 2 months, you can use it. So if you have these two candida, that is Lusitani auris, you should use echinocandid always. And you also need to do therapeutic drug monitoring for voriconazole, itraconazole, posaconazole, and 5-FC. And covered. This is one slide. If you have different type of antibiotic and different, carb expert, how to choose antibiotic. I'm skipping this. NDM, you should remember when NDM is producing, you have very few choices. That is azithromycin, ceftazidime, avibactam, and cefiderocol, except in one or two places where I have seen that there are imipenem or carbapenem added therapy despite NDM positive. For staff, there was one question yesterday night in the first WhatsApp group. So I put this last slide yesterday night only. Staphylococcus is a notorious organism. So all of us are aware that many of these, now community acquired MRSA is quite high. In our lab, our last HIC that data showed 40% of our, MRSA in community acquired staph infection are MRSA. So you should be aware that how to see MSSA and MRSA. And recently there is one mechanism which is found to be resistant even with the Vanco use is something called antigenic drift. That means if you see the data of say 2 or 3 years back and you see the recent data, the vancomycin MIC had changed. And even if it is in sensitive range, just because of increase in MIC, which is called antigenic drift, the vancomycin, they become either less effective or mortality is more. So despite Vanco, even if it is in sensitive region, because of this phenomenon of staph of MRSA, there is another phenomenon known as skip phenomenon. I don't know whether you have heard. Skip phenomenon in staph is notorious. That means you have high burden of staph. You take one culture, you take a second culture, say like infective endocarditis of staph. After 2 days, if you take repeat culture, it may be negative despite having organism because of low release of these organisms. And these escape phenomenon has been documented in staph. So when you are suspecting deep infection of staph and you are not getting 1 or 2 culture, you have to keep on repeating culture because 1 or 2 culture may be negative because of this typical phenomenon of staphylococcus when the burden of bacteria is high. The another
Dr.
pointer
Balmukund,
I want to
please
that
compile, sir.
lung with necrotizing pneumonia, the newer evidence for MRSA recommends linezolid may be better than vancomycin. In fact, it has been adopted by the European now that there is one meta-analysis of 7 randomized controlled trials that the outcome of linezolid was better, microbiological outcome. However, the mortality was similar from vanco with the linezolid. So if you have a necrotizing pneumonia, and especially if you had PVL secretor, linezolid may be better antibiotic than the vanco. So, however, you should be aware that most of the Western guideline still recommends for life-threatening infection vanco.
Sir, please conclude.
Yeah, so this is last take-home message. Yeah, I have finished. I'm open to question if somebody has any.
Hi, Dr. Balmukund. We can see the passion with which you have presented the slides, and it is very, very informative. And actually, it's an eye opener for many of us. So I would first ask Dr. Puneet Puni, madam, to please give some words for the participants' take-home message.
Yes, I mean, that's the beauty of our profession. I've been in intensive care for more than 25 years, and still there were few things I learned new. So thank you for such a elaborative, exhaustive, and very nicely presented, especially for all of us and fellows. It will be very useful. I just want to add here that as compared to developed countries, our incidence is much higher. I mean, it's almost 18 to 20%, and almost 46% in extremely preterm. And for all the families, especially, I want to say that we all know pediatrics, prevention is better than cure. So let's do the basic things which are the simplest and the best, starting from hand hygiene, starting from removing the invasive devices at the earliest. So less is more, less invasion, less infection, more hand hygiene, less infection. And that is a way we can prevent. Otherwise, no matter how many sophisticated tests we get, no matter how much thousands of antibiotic we get, ultimately we all are going to succumb to infections, because one day we are also going to reach the hospital. So that is the most important thing. My message is, let's do something more for prevention right from the beginning, and let's as IAP body, let's do something so that chemists, RMP are not giving third generation antibiotics for common cold, which is always viral. So it starts from actually the ground root to prevent infections in our ICUs, because in our ICUs we see patients who are getting cholesterol from outside and it turns out to be Kawasaki disease. So just thinking that all fever means infection, that is, I think, where we should go as an IAP body also. Let's prevent these infections. That is my thing, but otherwise beautifully represented. And one more comment, we are also getting biofire in DMC, but I would like to ask Dr. Bal Mukund and Dr. Maninder and other specialists, Dr. Shalu also. We used to get it and it costs is 16,000, sometime 20,000 they cost. It cost is very high. And we would get 3 or 4 bacteria, 1 or 2 viruses, and then lots of NMD, these all these terms, OXA, KCP, all those things. And it actually did not help us practically. For that, we were seeing the clinical criteria with the ball culture that was helping us more. So any comments on that? Because the report you showed was very specific, 1 bacteria with the NMD thing, but we get many bacteria, many viruses, and so we have stopped because the cost is too much, 2 to 3 days of ICU stay, and it doesn't help us. Thank you so much again
That's
for
the problem with this PCR based test, ma'am, because many of these colonizer also will be picked up by
it's
many of
very
these colonizer. Like if you see many of these respiratory, chronic respiratory condition, many of these bacteria get colonized. So you will get positive. So that is the problem. So if you have, you should send only when in a particular patient, like you are suspecting VAP, you should send PCR based test. Otherwise, don't send, ma'am.
yeah,
And if you are getting multiple positivity, you have to probably omit that report. You cannot, it's very rare that 4 organisms, 5 organisms are there. It does
yes,
happen with us also. Many times BCID, we get multiple bacteria, and that time we generally cover 1 or 2 which we suspect maximally and which your HICC data is showing. And that's why it's important to attend all HICC meeting and see what your hospital data is showing. Like if you have BAP, what is your HICC data showing? Despite having 3 or 4 positivity, please cover 1 or 2 organisms, which is much more common in your particular PICU setting.
thank you so
Yeah,
much.
ma'am, whenever we are seeing multiple organisms, I think we should go back and see how the sample was collected. I think that is important, because most of these times what we have also seen, ma'am, is that when we grow these multiple samples, the resident has taken a shortcut and taken a sample which usually gets either contaminated or maybe not taken properly, I think. And since these biophiles are so sensitive mechanisms, they
Yeah,
can pick each and everything, whether they are contaminated or non-contaminated. They will bring out everything what is there in the sample.
absolutely.
Even dead organism.
So there was one question about ceftriaxone plus azithromycin and typhoid. Over to Bal Mukund. Whether
Yes,
do you
so
think it's
that's
a sensible combination?
that is one randomized control trial from Nepal about ceftriaxone with concomitant use of azithromycin. And after that, there has been no trial. And what that trial found that there was slight difference in both. However, after that, there is no other trial. So presently, all the central bodies, including, our government recommendation is they use only one antibiotic. That is either ceftriaxone or azithro, depending upon the. I said the CMC has done this study. They have not published the data, but I know this study from the ID department that most of the Indian, except in those are though eastern and western neighbor, which I especially told that ceftriaxone. The only problem with the ceftriaxone use in enteric is that defervescence is quite late. It is 6 to 7 days. You have to be patient. You have to counsel parents each and every day, and give supportive treatment. They will respond after 6 to 7 days. However, you should know that in enteric fever, the adult people has already shifted to azithromycin as a drug of choice. So CMC Vellore, if you see the talk by their ID people, they are now recommending azithromycin as a drug of choice. But in pediatrics, we have not taken azithromycin as a drug of choice. Still ceftriaxone. I have especially said that in pediatric, ceftriaxone is still drug of choice. And drug regime yesterday was discussed about the dose. Actually, it's a quite controversial topic. What they found that even the lower dose of 50 to 70 mg per kg, that is around 50 to 75 mg per kg, is as effective as 100 mg per kg per day. So 60 mg, what yesterday Maninder was saying in the group, is perfectly fine. Even the lower dose of 50 to 75 mg per kg is good enough in case of enteric fever.
So one more question is about next generation sequencing.
NGS.
Yeah. So So newer, next generation sequencing is a evolving branch in microbiology, and it will come. It will come. Because now for each GNB and ESBL organism, it's important to know their genetic data and what enzymes they are secreting. It is going to come through, and it is actually already studies are going on presently in the Europe country, and CMC, ICMR data. It will come. So it is the future of the especially extended ESBL future is there, and NGS will come.
Lot of questions are still coming.
All
I think
these
so.
are
We'll take
scientific
it later.
data, what I showed just now. So without actually these data, the choice of antibiotics is extremely difficult. So that's why this is the future of your microbiology.
Correct.
Yeah,
so lots of questions are coming. I think so. We'll take it in the WhatsApp group only. So before we
we'll
close, I'll
take in the
take
WhatsApp.
one liner from Dr. Shalu Gupta about the session and some take-home point for students.
I have given this take-home point.
Dr. Bal Mukund has, I think, very beautifully elaborated some of the nuances of giving antimicrobials, especially if you talk about critical care kits. I think, and he had introduced some of the very important terminologies also. I think the fellows should note down that we should not blindly use antibiotics right and left. We should put a little bit of thought before we actually put an antibiotic.
And don't have the data of West. I'm telling you, the Western recommendation is totally different from ours. I've sold the data also. It is not that what I showed the data is actually true. The the same organism in Western is different from ours.
So, Dr. Bal Mukund, we often quote IDSA guidelines, and you have also quoted IDSA.
No. So IDSA is a baseline, but you have to see our own data. So IDSA is a one framework, but we have to see our own data, and you will be, CMC Vellore is, I found it's quite pioneer in this, and they are really doing this groundbreaking research, before anybody actually picks up. So all these, new Nacubactam and all those molecules, which are still not available in the market, and they are getting these research molecules, and they are doing a study on this, and they present these papers. And that's how we get this data.
Then another question, Dr. Bal Mukund, is that if we talk about MDROs and CRAPs especially, you told a lot of antibiotics, but what commonly is used is colistin or polymyxin.
So alone, you cannot use colistin alone. I'll just show that slide.
So monotherapy is usually not recommended when you are dealing with MDR or HDR organisms.
So in India, you should know, in India, if you have Acinetobacter, you need to know that it has to be combination therapy. Now, combination therapy earlier was high dose sulbactam plus cholesterol. All of us, we are using this, but this is not true. The recent CMC Vellore found that most of our Acinetobacter are having high dose sulbactam. That means their MIC was from 8 to 16, and that's why they are recommending now sulbactam dorolabactam combination along with the imipenem as drug of choice, because they found that these organisms, when they have MIC of 8 to 16, they have also PV3 problem. And this PV3 problem, when you use imipenem along with that, actually it improves the outcome.
No, the problem, Dr. Balmukund, is that this combination is not available. So
No, it is available. You can do Google. It is available.
Okay.
Yeah, sulbactam dorolabactam is available.
It is quite freely available.
MRP is around 3,800, 4,000 rupees. It is not available in government setting like we have procured this.
So this combination is better than the colistin?
Yes, this combination is better than high dose sulbactam with colistin. In fact, drug of choice now, because most of these has more than 4 MIC, is dorolabactam sulbactam plus imipenem. That is drug of choice. Second drug of choice is high dose sulbactam along with the colistin. This second, the outcomes are inferior.
Right. Dr. Pankaj want to say
plus minus cycling.
I think this was the perfect ending to our pediatric ICU course. What a lecture by Dr. Bal Mukund. I've really become a fan of yours, sir. Very nice. I'm a neonatal intensivist. We are dealing with these issues day in and day out, and it was an eye opener for me also. A lot of things I learned. I have a very special request to make. You have suggested a lot of things which we don't have to follow from European and US guidelines and have to follow our own data. Can you refer some paper or some written review article by yourself or some other Indian expert who have dealt and we can use it as a reference, because it's very
Dr. Pankaj, that is the problem, because most of these data actually they are taken from CMC. When you have, I'll request you to attend all the webinar of Balaji, Professor Balaji. He's a leading microbiologist of CMC Vellore, and he shows these data. You will be surprised, many of these are not available in public domain. It takes around 3 years from non-public domain to come to public domain. So many of these slides I have taken from him. I requested sir specifically to give me these slides.
Sometimes it become difficult.
Sir, can you please stop sharing the screen?
It becomes difficult in the group to be convinced about this data, as you can understand, being in a hospital with multiple consultants. So even if you say something which you want to emphasize.
Yeah, I know, I understand. But they come, but it takes 2-3 years for publication. Now, like Cefepime, like E. coli, if you see the molecule, the Cefepime Gedibactam, which will be launched by OCAT, they said in SEDEC, SIDSCON that by May it will be launched in 2000. It's already DGCI review. Means they have applied for license. It is under DGCI review. It will launch. Once it is launched, it will be game changer for all these E. coli, especially bug of E. coli, which Pankaj, you must be seeing a lot of E. coli, and it is a killer in few hours. 4 to 6 hours it kills in unit.
Sir, the truth is that in current day NICUs, we are losing babies only to infection. Everything else we are able to deal with properly.
Absolutely.
It's only infection, multi-drug resistant, which is killing newborns. Otherwise, there's no reason a newborn should be killed in this time. So we are really scared of this multi-drug resistance. We're really looking forward to some solutions. But as Dr. Puneet also very correctly said, prevention is the best strategy. But sometimes it is not in our own hand. Babies come to you with multi-drug resistant outside, refer to a specialty unit, and then you don't have anything else but to just juggle with the antibiotics. But an excellent session, sir. Thank you so much, Dr. Maninder. Thank you so much, Dr. Ajay, Dr. Sham, Dr. Shalu, Dr. Puneet, and all the teams, including Sushil. Sushil has been a backbone of our program, our executive from IEP Delhi. It's only because of his hard work that for last almost 48 weeks we have been doing this program every Sunday. So being getting up in the morning, doing every Sunday is not a joke. So all of us have done it. So a big clap for all of us, which we have been really doing it for last 1 year. and the legacy will follow. Dr. Ajay and Dr. Dinesh Goyal is going to follow this legacy, and we are going to learn continuing in 2026 also. With these words from my side, it is all good. Thank you so much.
Thank you so much for the opportunity,
Thank you,
Dr.
Dr.
Maninder and
Maninder.
IAP Delhi. Thank you so much.
Thank you.
Thank you,
you.
Dr.
And a
Maninder. Thanks
request
a lot.
to all the delegates, will be launching gastroenterology module shortly. To register for that also.
Keep on logging yourself and you will be entertained. Thank you so much. Thank you.
Thank you. Thank you, Dr. Bal Mukund.
Thank you.
Maninder.
Thank you.
Thank you, Dr. Pankaj.
Thank you, Ji. Thank you.